We've got a problem that I think most people don't understand the scale of. We're talking 28 million people globally not accessing care, 750,000 Americans, depending on which data you use, not in care, not accessing care. This is no way to stop a pandemic, especially given that treatment can double as prevention. So you all have been working in this field for many years. You're all superb experts. What does it feel like to think about where we are? We've made so much progress scientifically, and yet we still have this massive amount of people not being addressed. Where are we, and what does that make you feel like?
I think the science is amazing. Especially after the HPTN 052, when we discovered that a person who can successfully be on their medications and suppress their virus are really not transmitting the disease to others. That's wonderful. But I also have to deal with the reality, especially for me in the south part of the United States, where the resources are so thin, and we can't even get everyone on medications. So, in the United States, the richest country in the world, we have thousands of people on waiting lists for medications.
How do we have such a large amount of people out of care? And for me, HIV has always been an example of a larger problem in our society, particularly in the United States, which is we've seen this, chronicity of HIV start to represent the issues we have overall with folks accessing care, whether you have HIV or you have diabetes. And that has to do with a mistrust of the medical institutions. These are systemic problems. It has to do with folks not prioritizing their health because they're looking for food and shelter. I think we're really starting to see that nearly that million people are actually people who really have been failed by our social systems.
But we covered 26 counties of South Central Alabama, most of which is very poor, most of which is very rural. And yet, many of those counties have some of the highest per population HIV rates in the country, 4 times higher than the national average. So why is this? And the realities of trying to get people tested and in care when there's already a national shortage of HIV providers, that's worse in the South. So you have people with poor education systems, without much money, without understanding they're at risk, who live in counties that don't even have primary care doctors, much less HIV doctors. They don't have hospitals. They don't have hospitals that deliver babies in multi-county areas. They're having to get transportation to go a couple of hours away to get to a doctor. And we begin to see this social system that doesn't work, these structural barriers with funding, with poverty, with stigma, which is huge in the South around the HIV issue, with domestic violence, which is a major barrier for women at protecting themselves from HIV, and the whole access to care delivery system that is really failing people and failing the most vulnerable people. So we come up with these numbers that are outrageous.
For those who can access care, we have one message. You can be well. You can live a long and normal and healthy life. But for those who don't access care, we're talking death sentence still, right?
Absolutely, and I think it's because HIV in the United States is, people call it the invisible epidemic, but I really think it's, the denied epidemic, because it is about all of the issues that we've been talking about. It's about, poverty, it's about stigma, it's about racism, it's about these structural barriers. And so if we were to address it in the United States, the ways that we were able to address it or have been able to address it globally, it means acknowledging a lot of things we want to sort of sweep under the rug that happen domestically, and we don't want to talk about racism, we don't want to talk about violence, and we don't want to talk about stigma, we don't want to talk about homosexuality or drug use, and all of that is intertwined with HIV. And so the sort of denial around it prevents us from getting the political will that you were talking about, Kathie.
Right. In order to address this, we're going to have to fix society. We're going to have to fix our healthcare system. We're going to have to fix a lot of things that have needed to be fixed for a long time.
Super
right?
easy.
The good news is we solve all the world's problems. The bad news is we have to solve all the world's problems.
But I think that's really true, and to build on Cynthia's earlier point, when we've been looking at some of the reasons in a number of cities why people are not in care, a lot of the issues are basic things like transportation, homelessness, food safety, and I think because, Regan, as you said, people think that HIV is over, we not only, I think, as a nation think that, but we also don't pay attention to these fundamental determinants of HIV, and I think we're going to have to address those if we're going to ever change the unmet care needs in the U.S. I also think, too, to your earlier point about how the U.S. compares to some other countries. In Baltimore, for instance, about 45% of young black gay men are living with HIV, and according to some surveys, about 74% don't know that they're living with HIV. And when we look at why that is so, one of the major predictors is not having insufficient access to health care. It's not having any access to health care. And so some of the solutions, I think, will be driven inside of the healthcare system, but they won't all be, because some people don't have any access to health care, and we have to keep that in mind, too.
That's a good point. I mean, the question is, we've been talking a lot about how we deliver care in America and how we can improve it, but we're talking about a lot of people who aren't even in that consideration set. And if we improve those systems, it's not going to touch them anyway. So you all are out there in the field. How do we reach people who are not in the care system? I mean, that seems to be one of the biggest common denominators, no matter where you are in the country, that if people are not coming into the healthcare system, where do we go and find them?
I think it's, we're in this really odd time where we have all these incredible medical tools that can really improve people's health, avert new infections, and yet half of people living with HIV aren't receiving the medical care and treatment that could save their lives and slow new infections. And it's a travesty that 600, 700,000 Americans with HIV don't gain access, and there's enormous barriers, and it's a complex web of issues. But it also comes down to two basic things: inequality. So inequality for health services, housing, preventative health, education, kind of a whole spectrum of inequality, and then stigma. HIV stigma is still a very powerful force. It keeps people from accepting testing, accepting the medical care and treatment and assistance, and heal, their trauma around HIV diagnosis. And so we have to deal with these directly. We have to deal with the inequality around all of these issues, and we have to deal with stigma. We're not going to make progress against HIV without confronting, both the internalized stigma of people living with HIV as well as the societal stigma and discrimination that continues to pervade everything we're doing. I
know for us, when we're going onto the streets and doing outreach and finding people that we know are out of care, and we're like, what's going on? How can we link you into care? For a lot of them, it's like, I tried, but then I got judged when I was there, or my family doesn't know what I'm dealing with, and there's no way I'm going to let them know, and I'd rather die. There are so many complex issues, and I think that for anybody, following regular medical care is pretty hard. I think it's not something that we should say is an easy thing to do, but I think when you put any barrier on top of that, we have to get really creative. I think that's going to really be part of our solution, is how do we make healthcare systems actually attractive to people who want to go in? It's just like, how do we do that? We work a lot with the incarcerated. The moment they're out of jail, they are not going to go back into another system because they feel very vulnerable. They've just gotten out of a system that, again, a lot of inequality. So I think trying to create systems, we're so good at marketing and other things, maybe we could market our social institutions to make them more attractive.
It's a real opportunity to raise the comfort level of physicians, and then also make people understand that they have rights as a person going into a system. And that's something that we see a lot in POZ, where people come into the community, and people who've been at this a long time help other people understand that you have a right to be treated with respect. You have a right to access to care. And the self-empowerment that can come from being around other people living with HIV and teaching each other that this is something that you should not be ashamed of. This is. I think your point about stigma, David, is excellent, because there are two kinds. There's the stigma that we perceive society puts on us, and there's the self-stigmatization that I think people with HIV face.
Part of the paradox I think we're living in right now is that we're on the cusp of seeing increased health services for Americans and health insurance. And it's very exciting. It's something we've been fighting for since the beginning of the epidemic. But this new wave to improve access to health insurance could result in fewer services that are catering to the needs of people with HIV. And we want the general healthcare system to respond and be friendly and be, know how to appropriately provide services to people with HIV and the populations most at risk. But we could find ourselves, if we don't stage this correctly, in an era where we have more health insurance access, but fewer people in care. Because if kind of the general healthcare system is not ready or willing to serve people with HIV with the care, compassion, invitation that people need and deserve, they won't go. And we're already seeing that, and it's a scary time. So we're seeing the AIDS infrastructure kind of being dismantled. And I'm not sure that we can, we're going to have to really work hard to both make sure that the general health infrastructure is appropriate and that we preserve some of this specialized infrastructure. I think we need both.
We all hear so much today about treatment as prevention, PrEP and PEP, and all the wonderful medical tools that we have. But as someone living in an area of the country that is extremely poor, has very poor educational systems, not a lot of health insurance, not a lot of access to quality care. Certainly all of those systemic issues are critical. But for people living with HIV in the South, and I'm sure other places as well, the HIV oftentimes is not their most pressing issue. If they are homeless, if you have a woman with children, she's going to put their needs ahead of her own medical care. If she's in a domestic violence situation, substance use issues, mental health issues, which, those two items carry their own sort of stigma as well, as does domestic violence. But, if we don't make sure that we deal with all of the complex issues, then we're not going to be able to keep people in care.